Good afternoon and welcome to the session which is entitled Managing Peripheral Neuropathy in WM. You've got the London gang up the front here, so you all met me, I'm Bob, and it gives me great pleasure to introduce the two speakers this afternoon. I'm not going to tell you how clever Professor Shirley is. You can read about that on Google and in your brochure. What I'm going to tell you is what a wonderful human being she is. I've known her now for 5, 6, 7 years. And in that, she's not my doctor, by the way, but in that time, she cycled from London to Paris with me to raise awareness of WM and to raise money. She's done a live podcast with me, or a webinar with me, whilst driving her daughter's sick cat to the vets and back on hands-free, asking questions about neuropathy. And, sorry, I've lost my... And more recently, she taught me how to split the G in a seedy pub in Dublin. And if you want to know what that is, you'll have to ask her afterwards. So I'm going to introduce Professor Shirley Dessart. And with her today is a consultant neurologist called Junie Shiwen. And she's a consultant neurologist in Queen's in London, which is the National Hospital for Neuropathy and Neurosurgery. So we've got the best of both worlds. We've got a top hematologist and a top neurologist, that's it, to speak to you. So Shirley and Junie.
Thank you very much, Bob. And I know we have a very competitive speaker next door, so thank you for joining us today. I think everything's being recorded, so we can all look at Zach's presentation later. So I work at University College Hospital in London, and it's a big sort of teaching hospital which has many hospitals attached to it. One of them is the National Hospital for Neurology, which is about 10 minutes walk away. And many years ago, myself and some colleagues started doing some joint working in the IGM setting so that we could see patients together in the same room. And it's been a very fruitful process over many years because it's quite difficult to, as a hematologist, to work out what's happening in the nerves. And for the neurologists, they need to understand the complexities of a disease like WM and the IGM. We heard Shayna's excellent talk earlier, giving us news about all the various unwanted talents of IGM and the things it can do. So I'm really pleased to have with me for the first time at an ED forum, a neurology colleague who is, in this case, Junie Shiwen, who works with us in our neurohematology service. So we're going to do a double act. And if you're still awake at the end, I will tell you what Split the G is all about. So the overview of our talk is to give you a sort of background into what the peripheral nervous system is, how it looks, how it behaves, what it needs to function. In fact, Maury Gertz did touch on this earlier with his amazing artwork on his tablet. We talk also about the key questions that arise in our practice in the neurohematology clinic. And we're going to use 3 cases to illustrate our discussion, which I think is always a really good way of trying to understand patients' journeys and their experience and how doctors manage that. And we'll also we'll finish off with the important things you can do when you have an interaction with your doctor as to how to help the doctor to help you.
Thank you, Bob and Shirley. So everyone, I'm Junie. I'm a neurologist from London, working with Shirley in the Joint Neurohematology Clinic. And so I'd like to just start off. You've had a little bit about the nervous system already and the various ways it can be affected in WM, but this session is obviously focusing in more detail on that. So I wanted to give a bit of background about what makes up the nervous system. So it's sort of roughly divided into 2 parts. You've got the central nervous system, which is mainly your brain and spinal cord, and the peripheral nervous system is the bits outside this. So in the head, you've got the cranial nerves, that were mentioned in the previous talk. And below the neck, you've got the nerve roots coming out and then into the rest of the peripheral nerves that supply the sensation on one side and receiving all the sensation from the body. And the other side, there's an output into the muscles. So sending a signal to cause your muscles to contract to get enable movement. So those two parts, the sensory and motor nerves, make up the somatic nervous system. And you've heard from the talk earlier, there's this separate system called the autonomic nervous system that actually supplies all the different organs in the body and operates without your conscious control. So if you imagine when you got out of bed this morning and opened your eyes and you stepped out of the bed, when you stand up, what the blood vessels tend to do, if you have a healthy functioning autonomic nervous system, is they squeeze together a little bit more tightly so that your blood pressure is maintained. Where this isn't happening, the blood will tend to pool with gravity, so it sinks down to the bottom, and then you might feel lightheaded every single time you stand up if you have autonomic nervous system failure or autonomic failure. And that is an important component of one of the potential complications of WM. And then just continuing that sort of metaphor, if you imagine when you got out of bed this morning and let's say you opened the window, when light comes in, one of the things your pupils do automatically without you thinking about it is they constrict a little bit so that they become a bit smaller in bright lights. If they didn't do this, you'd be very bedazzled every time you stepped out. And then if you then went on to eat your breakfast, you're automatically producing saliva to help you to swallow whatever dry or moist foods you might be eating. And then you go to the loo and empty your bladder and evacuate your bowels, and all of that is controlled through the autonomic nervous system. So it's sort of always there in the background, ticking away and making sure that everything is at a status quo. And it's got two main parts, the sympathetic nervous system, which is sort of your fight and flight response that becomes activated when you're more stimulated, and then you've got the parasympathetic nervous system, which is the rest and digest one. So they operate into two separate nervous systems within the autonomic nervous system. So when things go wrong, I've spoken a little bit about the autonomic nervous system already, but you might have problems of lightheadedness when you stand up, problems digesting the food, so feeling full very quickly, problems with the bladder, erectile dysfunction in men, problems tolerating heat or changes with your sweating. And then if you've got sensory nerve problems, you might have numbness or sometimes excessive sensitivity to normal stimulation, or painful, where you misinterpret that pain, or sometimes you have spontaneous pain even without any provocation. And within the sensory nervous system, you have two main types of fibers. You've got small nerve fibers that carry mainly pain and temperature, and large fibers that carry your sense of vibration and joint position. So those nerves tell you where you are in space. So that's very important for your balance. And then on the motor nerves, they mainly supply, they tell your muscles to contract. So if they're affected, you might have weakness, changes in your walking, and other changes that we can see and observe on the examination, like a change in how the muscle appears. So this is the approach that we tend to do together in a joint clinic. So as you've heard already, all those symptoms could actually, they're not very specific. So in the talk earlier, you heard how when you have certain symptoms, they're not necessarily related to a neuropathy. So part of our job is to figure out if the symptoms that you're describing are related to a neuropathy. And that's through listening to the story and examination in the clinic and a number of different tests. And I'll use the three cases to basically illustrate what we are listening out for in the story, what we then look for in examination, and how we then decide what tests to do to help us to figure out if there's a neuropathy, what the pattern is, and if it's related to the WM, and how is it related, because that all enables us to decide then what should we do about it, both in terms of treatments and chemotherapy and the sort of more heavy duty stuff that Shirley and her team deliver, but what are the other supportive measures that we can do for a neuropathy? Because they can be really important as well. So they're all cases that we've seen within the last year, and in some cases I've sort of amalgamated them to try to make specific points, but they're all real-life cases that we've seen in our clinic in the last year. So the first gentleman, I've changed all the names, so this man, I've named him Alan. He's 64, and he has a 4-year history of symptoms that started with pins and needles in the toes that gradually spread upwards to the knees, and then at that time his fingers and hands became affected. And he also told us about a tremor he had, which isn't something that many people have spoken about so far in this meeting. That's a key feature of one of these neuropathies that we manage and see. And he'd also noticed that his balance was poor. And I tend to ask people when they complain about poor balance, how are you if the light is not so good, so in the dark? And especially if you're having a shower, what happens if you have to wash your hair or if you have to wash your face? Because most people will shut their eyes when they do that. So that's a very good sense, that's a very good clue. If they're not able to do that, it's a good sign they've lost their joint position sense from their body, because your balance is, from the nervous system point of view, heavily influenced by the signals that are coming in from your body, as well as visually. So if you remove the visual cues and then you're much more wobbly, that tells me that you might not be getting enough sensation coming in through your peripheral nerves. So he said that he was more unsteady with his eyes closed and his walking was unsteady. And when we examined him, this is something that we see. So we often get someone to just stand and observe their walking and how they walk. So some people may walk, if they're unsteady, on a slightly broader base, just to sort of widen out the center of gravity, basically, to make them more stable. And they're not able to walk as if they're on a tightrope. So that's something we do in clinic to try to see, can they walk on pretend they're on a tightrope, and that was difficult for him. And then when we got him to just stand and close his eyes, he was much more unsteady when his eyes were closed. And he actually had full strength, so telling us the motor nerves were actually not bad, but he had lost all his reflexes. That's something we check with a tendon hammer that many of you may have had done when you went to a clinic. But he did have loss of sensation to all the different modalities. So if you were listening earlier and you remembered which carried the information of the large fibers, so he had the large fibers affected because they reduce vibration sense, which we check with a tuning fork, basically, all the way up to his ribs. So all the way in his legs, he wasn't able to feel that vibration. He could only feel it up to the ribs. And then he had a little bit of impairment of the joint position sense in the toes, and he had loss of the pin sensation to about the mid-shins. So there's a difference in the degree to which the different fibers were affected, with the large fibers more affected than the small fibers, but both sets of fibers affected. So that is the clinical examination. And then the next thing we tend to do, which we consider part of the clinical examination, is actually the neurophysiology or nerve conduction studies. And so the general principles of that are, if you consider a motor nerve, you've got the wire, the axon, and you had a little bit of that earlier, and you have myelin or insulation wrapped around it, and that helps the nerve function, because the electrical signal, instead of having to travel all the way down the nerve axon, it's able to jump between the uninsulated bits, and that speeds up the connection significantly. So if you get a loss of the myelin, you get a slowing down of the signal, which we can see on the electrical test. The time taken is longer. And if you get loss of the axon, the actual wire itself, the size of the electrical potential is smaller. So when we look at those two parts, we can get some clues about which part of the nerve is affected. Is it the myelin or the axon, the insulation or the wire? So in his case, there was slowed conduction, suggesting it was a myelination problem. And in particular, when we compared the slowness of the different sections of the nerve, the ends were the most affected and the slowest. So we call that, the technical term for that is prolonged distal motor latency. So that's something we see on the electrical tests. and it's quite characteristic for this particular condition that is associated with WM called anti-MAG neuropathy. So in his case, he had this IgM paraprotein, and he had strongly positive anti-MAG antibodies, and he had a relatively low level of infiltration on the bone marrow. But in his case, this very clear story of a neuropathy that we know it's really characteristic, actually. So his story and his examination and his electrical tests all fit very strongly with this phenotype that we understand as anti-MAG neuropathy. And if we didn't, because it was so clear-cut in this case, we did not do a nerve biopsy, but this is a nerve biopsy from another patient who had a similar presentation. And so with a nerve biopsy, to give some information about when we do that test, we tend to do it if it's not straightforward. So in this case, fairly straightforward, so we probably wouldn't have done it. But if there were other atypical features, and you'll see some other examples of atypical features in the next two cases, like if there's significant pain or if there's significant weakness, and we don't think it's a straightforward anti-MAG neuropathy, we might do a nerve biopsy to look for other things that may need different treatments. But if you did do it in an anti-MAG neuropathy case, you see evidence of loss of myelination, and specifically for anti-MAG, I don't know if I can show you. Can you see? I don't think you can see which bit. That's back, I think. So if you this gray bits, so the purple bits over there. That is an initial view that we get when we look at the nerve biopsy. So this is a sort of larger view of the whole section of nerve. And that purple bit there is an individual nerve fascicle. So we can see that within that, if you look at the little purple rings, the purple rings are actually the myelin. So you've got loss of myelinated fibers that you can visualize on that. And then the bit at the end, that skinny bit over there, is you can see some bits of that, there's loss of the myelination. And the gray sections here are a special test we do called electron microscopy. So we're looking really at a very zoomed in version of what the nerve structure looks like. And you can see the box in red, the circle within that, the axoplasm, that's the axon, and it's got the myelin around it. And what it should look like is that thick, dark bit, because all the myelin should be very tightly wrapped together. But in this case, you can see from the zoomed-in version here that the myelin has separated out. And that's because the IgM paraprotein is forming antibodies, which are these anti-MAG antibodies, that bind and get stuck, basically, between the layers of the myelin, separating them out. So the myelin is damaged, and we see that as the conduction slowing on the electrical test, and we see that as all the manifestations that we found on examination and that the patient was reporting, essentially. So it all fits very nicely with this neuropathy that is very well described. So in this case, all the symptoms, is there a neuropathy? Yes, that's our first question. What's the pattern of the neuropathy? It all fits with an anti-MAG neuropathy because of all the reasons we said. It's a gradually progressive one with conduction slowing on the electrical test. It mainly affects the ends of the nerves. And the type of symptoms people have is that they've got numbness with unsteadiness and typically tremor. And when we sort of make that diagnosis, then we sort of ask our hematology colleagues and try to decide together with the patient what is the best course of treatment. So if there is a progressive neuropathy that is impairing function, and we're clear that it's linked to the WM, and if the patient is younger or things are rapidly changing and there's been less than 5 years of disease, there's more likely to be a benefit by introducing certain treatments. On the other hand, if there's been, let's say, 10 or 20 years of very, very slowly progressive disease, and it's not been so bad, actually, the person is still functioning quite well, then we may consider that actually in that case, it might be more appropriate to do more supportive treatment. So I'll let Shirley talk a little bit about the sort of clone-based treatments, and I'll talk a bit more at the end about the more supportive treatments that we use as well.
Thanks a lot, Junie. So, as Maury Gert said earlier, it's the weeds that are causing the problem, and the question is, when do you bring out the weed killer? So in this situation, because this gentleman has had his condition for quite some time, we were really weighing up whether we should go ahead and treat him. He clearly, in our opinion, had an anti-MAG neuropathy. He'd had it for a few years already. And so if we were going to treat him, because his bone marrow had some WM in it, should we go ahead? Now, hematologically, he didn't have any need for treatment. His blood counts were fine. His bone marrow level was very low. I think his IgM level wasn't that high either. So we could give him either rituximab, which is the anti-CD20 antibody. If we give that an anti-MAG neuropathy, we usually give it weekly for 4 weeks. It's intravenous by and large, but it can be given subcutaneously. It's usually given weekly for 4 weeks and then stop. It takes a while to see stabilization if it's going to work. Sometimes it can improve patients. It depends on how much of a deficit they have already. If a patient needs treatment and they have a sort of bigger clone in their bone marrow, so not the monoclonal gammopathy of uncertain significance, but more like a Waldenstrom level of disease, we might well consider giving them chemotherapy with the rituximab, because that's a bit more definitive, and probably the treatment will last longer for them. BTK inhibitors, such as ibrutinib and zanubrutinib, have also been used in anti-MAG neuropathies. They can be effective because they're treating the underlying seed that causes the problem, the cells, or rather the weeds, I should say. So that is the principle. So in general, and it's accepted by most people, and in fact recently there was the international workshop on WM and there was some consensus guidelines written. Everyone agrees that you should only treat anti-MAG neuropathy if there's significant or progressive disability. The reason is that the weed killer can be dangerous. And unless there is a good reason to treat, you do not want to expose the patient to potentially dangerous immunosuppressive therapies. We know also that outcomes for neuropathy and improvement are likely to be better if there's less nerve damage, because nerves take a very long time to recover, and sometimes there's a point beyond which they will not recover. What we don't know is whether we need to see a very deep reduction in the anti-MAG antibody level. So we have categorization of when the anti-MAG level is likely to be significant. There's high levels, medium, and very low levels. And many people who don't have any IgM problems may have low-level anti-MAG antibodies, because that's just part of the normal repertoire of our immune system. It doesn't mean anything. But the higher the level, and in our lab and many labs across the country, it's greater than 70,000 BTU, as it's called, the Bullman-Titer antibody. That is more likely to be instrumental in causing nerve damage, provided you have the right clinical features. Because sometimes you can have an anti-MAG antibody, but it just coexists with another cause of neuropathy. And that's why we deconstruct the whole story in our clinic. So what we don't know is how low does the anti-MAG need to go in order to get the response that we want? And oftentimes, you can give treatment and the total IgM falls, but the anti-MAG doesn't really fall. And as you saw from Junie's slides, once the MAG antibody is sitting there in that onion sort of skin, onion-like effect, no treatment is actually going to extract it out of there. It's sort of there. So the idea is to stop further deposition of anti-MAG antibodies. And actually, with all our treatments even now, it's really very difficult to completely eliminate every WM cell. So the so-called cure is quite difficult. Depends how you define that, of course, but So when we have a patient who's otherwise well, we do not want to be too heavy-handed with chemotherapy and immunotherapy, because that is like using a sledgehammer to crack a nut, and you don't even know what benefit you're necessarily going to give the patient. So quite often, I think it's important to emphasize that stability rather than a categorical improvement is often all we see in the setting of neuropathy. And the various treatments that have been tried over the years include intravenous immunoglobulin. I think many people I've heard in my practice have already had immunoglobulin treatments because they think, or their doctors think that they may have something called CIDP, which is chronic inflammatory demyelinating polyneuropathy, which is a non-clonal disease, and it's more common than IgM-related neuropathies. Steroids can be used because these neuropathies are inflammatory, but you cannot use steroids for a prolonged period, and even high doses don't necessarily do anything to the actual pathology. As I mentioned, rituximab can be useful, can be given in combination. The thing is, the more toxic the chemotherapy agent or the more strong, potent, the more likely you are to leave more side effects to the patient. Because once you give something like bendamustine to a patient, you can't have it back. Whereas rituximab alone can cause immunosuppression, but for lesser time, and there's potential for recovery. And there are trials actually going on with also the BTK inhibitors. I think Jorge Castillo is running one trial with the zanubrutinib in anti-MAG, and there's some European trials as well. So hopefully, with time, we can figure out how these drugs work in these patients in particular.
So if we choose to give clone-based therapy, and if we don't, there's often a lot that we can do from a supportive side with medications and non-medical related physical therapies or other supportive things. So it's not common to have pain with anti-MAG neuropathy, but other neuropathies can result in pain. And we've got a number of different agents that can help with pain, including gabapentin or amitriptyline or nortriptyline, we commonly used in clinic. The tremor was something that this gentleman had, and that can be problematic. So from a non-medical point of view, there are some simple things you can do for that, such as avoiding things that make it worse, like excessive caffeine. But there are also medications that help to calm down tremors. So a beta blocker, propranolol, is something we commonly use for tremor. And gabapentin, which is used for pain, does also have an anti-tremor effect as well. So there are a number of different medications that we can try if the tremor is problematic, and going up to more invasive things like a Botox injection or deep brain stimulation if it's particularly severe. And from a more practical point of view, just if you've got reduced sensation in the feet, taking care of the skin of your feet and making sure you're wearing sensible, comfortable shoes. And if there is weakness over time, then you can have support to the ankles. So that level of support you need depends on how severe the neuropathy is. So if there is mainly sensory loss with a very mild weakness that only becomes apparent when you're walking, when you're in the sort of swing phase of your walk, then you can have sort of braces that attach to the ankle with a strap to the laces. And that just provides a little bit of support, but it's very comfortable. And that just supports the foot as you're raising it with each stride. If you've got more severe weakness that is affecting your ability to raise the ankle and sort of stand on your tiptoes, so you're not able to stand on your heels or your tiptoes, you might need a more stable support that is more rigid. But that is often tailored for each individual and depends on the degree of sensory and weakness that you have in different directions. And what's affected mainly, is it you're unable to stand because there's so much instability there, or is it just mainly the walking and you just need a little bit of additional support? So looking at that in more detail as part of the holistic care of someone with a neuropathy. And if things are more severe, do they need something like a stick or a frame to help if they're really unsteady, and considering other modifications to the environment as well. So in summary, for this first case, there was a neuropathy, which was an anti-MAG neuropathy. He was sort of in between what we would consider as a clear-cut case for going in with treatment like rituximab versus deciding whether or not we should go towards a more supportive watch and wait approach. If we were to go down that route, or even if we did go down the clone-based route, we would also be considering supportive treatments like propranolol and gabapentin to help with that. So moving on to the next case is a slightly different combination, but starts off not too dissimilar. So another gentleman called Ben with 3 years of symptoms. He used to commute to work by cycling. So he had a half an hour cycle back and from work, which he managed with no problems. But during the COVID pandemic, he realized that he was unable to cycle because he felt really unsafe on the bicycle. And then gradually his walking became affected too. So the walking became unsteady. And then he noticed numbness in the feet that gradually came upwards, and then also became the hands became to be affected with reduced grip as well. He was worse in the dark, and he had to sit down to wash his hair, so he was worse with his eyes closed. And he also had some weakness going up the stairs. He needed to use the handrail to pull him up the stairs. And just from when I listen to a history point of view, the stairs is something I always ask about, because if you've got difficulty going upstairs, that suggests, it could be for a number of reasons, but from a neuropathy point of view, it suggests you probably have some weakness higher up in the legs as well. Whereas if you've mainly got difficulty going downstairs, that could be because of a lack of sensation, just affecting your stability and making you a bit more cautious when you're going down the stairs. So I always ask this sort of things to get a flavor, and before we examine them, about what they find most difficult and what clues does it give you about where in their nervous system is affected. So far, we know the sensory nerves, the motor nerves are affected in him, and that's one of the differences between this case and the first case. And then when we examined him, he walked with a high step-edge gait. That's the term we use if some people have weakness of the ankles. That means that they would otherwise be dragging the feet. So to get over this, many people compensate by lifting their feet quite carefully off the ground as they walk. And then when you actually examine the strength of each muscle, which we do in every clinic, he had weakness at the ankles. So dorsiflexion is doing that to the foot, and plantarflexion is going down, stepping on your tiptoes. So he had weakness of the ankles that was a bit asymmetrical, more significant weakness of the toes, which are obviously more longer nerves. So it's a length-dependent pattern, and also had weakness in his hand muscles as well. Again, he had no reflexes when we checked them with the tendon hammer, and he had a loss of vibration, joint position, pin and cold sensation in his arms and legs in a quite a symmetrical manner. But you can see from the numbers that I've used to document the strength. So when I've used one number, that means it was the same on both sides. But when I've used two different numbers, it's because the left and right were a bit different. So there was a degree of asymmetry in this case, which wasn't present in the last one. And when he had the electrical test, he'd actually been seen by a different neurologist before coming to us. He did have this conduction slowing, which suggests demyelination, but it was quite patchy. And when we repeated the test, they were actually a lot worse in a fairly short space of time. And he did have this paraprotein. And because there were some unusual parts to his story. There was this asymmetry on the examination. He had quite significant impairment. We did a few other tests than we did for the other gentleman, essentially. So we went on to do an MRI scan, and these are the pictures of his MRI scan. So at the base of your spinal cord, you've got a number of nerve roots coming out. That's called the cauda equina, or horse's tail, because of the appearance of these nerves. And they looked thickened. And when we do MRI scans, we do plain scans usually, and then we inject gadolinium, which is a contrast agent. And this, if it lights up, it suggests that there's something active, there's an active process going on there. So his cauda equina nerve roots were thickened more than we would expect, and they were also bright. But this is not something specific. So it tells us there's something going on there, but it doesn't necessarily tell us. It could be just an inflammatory problem like the condition Shirley mentioned, CIDP, chronic inflammatory demyelinating neuropathy, or it could be something related to the WM. And in his case, he actually had received the diagnosis of CIDP, and he had that first-line treatment, IVIG, but with no effect at all. So again, that was a red flag that he didn't have a straightforward inflammatory neuropathy. So we went on to do a lumbar puncture. And actually, the lumbar puncture he had with us was the second lumbar puncture, because he had an initial one at his local team where they found a raised protein. And again, that's not very specific. It can be seen in inflammatory neuropathies as well as other conditions. In his case, we know that if you take off a very large volume of fluid, then that increases your sensitivity at picking up particular abnormalities. So we took a large volume. We take at least 10 mils, which is a lot of CSF to take, but your body's always producing it all the time anyway. So if you're going to take the sample, you might as well take a decent size sample. And then we did a number of different studies, including genetic studies and flow cytometry that actually showed there were a small number of cells there, but they were all what we call clonally restricted. They all had these molecular markers, and they were all the same. And this actually suggested that his, we also did a bone marrow that showed infiltration of the plasma cells, so 15 to 20% infiltration, so making him a diagnosis of WM. But then the fact that these cells had gotten into the spinal fluid, it actually told us that his diagnosis was something called Bing-Neel syndrome. So Bing-Neel syndrome is the term we use when WM has affected the nervous system, typically the central nervous system. And you saw in the earlier talk of patients who had MRI scans, who had different changes in the MRI of his brain. So he didn't have any problems with his brain, but where his nervous system was affected was the nerve roots and then the spinal fluid. And that was the cause of his neuropathy. So that was the diagnosis. Then we asked Shirley, what should we do about treatment?
Thanks a lot. So, yep. So it's interesting, this sort of evolution of his symptoms has some similarities, but there are subtle and not so subtle differences. And the testing regimen gave rise to the answer in the end. So when someone has, we have this thing called the blood-brain barrier, which protects our brain from toxins, really, and bacteria and so forth. And it's also not something that IgM normally crosses at all, let alone cells. So if someone has a lumbar puncture in the setting of, say, meningitis, which is something that happens in infections, you may see an elevated lymphocyte count or white cell count, but that is in the context of an infection. Whereas in the context of WM, if there's no evidence of meningitis or similar symptoms, fevers, etc., the thing that helps us understand whether these cells are actually WM is to do what's called flow cytometry and the molecular testing, which is what we did in our lab. Once we have evidence that these cells have crossed the blood-brain barrier, and that the reason it crosses we do not really know. It's a bit like the sort of extramedullary disease that was mentioned earlier. Why do these weeds leave the soil and go elsewhere? We don't really understand why that is, but it does happen. We then need to target the central nervous system with treatments that will go past the blood-brain barrier. And that can either, traditionally, and perhaps back in previous times, and in some diseases still, you could actually inject chemotherapy into the spinal fluid, very specific drugs which can help kill off the cells. Nowadays, we do not do that at all in the setting of WM or Bing-Neel, because most chemotherapies of that sort are designed to deal with very highly dividing cells, such as an acute leukemia. They're not as useful in WM, which is a slow, gradual disease. We can also use rituximab and BTK inhibitors, and Shana mentioned that BTK inhibitors do cross the blood-brain barrier. Rituximab doesn't generally, but in someone who's got a breached blood-brain barrier, then it could work. We also consider, what is the age and fitness of the patient. Now, if someone has Bing-Neel syndrome that's causing them to be unfit and immobile, then we have to bear that in mind when choosing the treatment, because if you actually treat the underlying disease, then their fitness will improve. And we also look at how quickly or slowly the disease has progressed and how severe it is. And that's what helps us decide how to treat. So I'm just going to briefly mention the issue of Waldenstrom-related neuropathy. So Waldenstrom-related neuropathy can affect about a fifth of patients, or at least, as I've said on the slide, symptoms of neuropathy occur in about 20% of patients with WM. But as time goes on, about half of patients are affected by some kind of neuropathy symptoms. And as Junie mentioned, a lot of them may have anti-MAG neuropathy, demyelinating neuropathies, but they also may have damage to the wire or the axon, such as usually when the anti-MAG is negative and through another mechanism such as amyloidosis, cryoglobulin, which you heard about earlier, vasculitis, or even when the cells, the WM cells, just actually invade the nerves, which they can do. So this is the kind of backdrop of the kind of neuropathies that can happen in WM. And if you have a Waldenstrom-related neuropathy, which of this kind, particularly when the cells are active or the paraprotein is producing more like a direct toxic effect, such as cryoglobulin, we basically treat the underlying lymphoma. So in this context, there is actually a significant amount of disease in the bone marrow. It's not just a monoclonal gammopathy, an MGUS, sort of less than 10%. So when we decide on treating someone with Waldenstrom's who has either central nervous system or peripheral nervous system complications, we need to be quite careful as to how we evoke our treatments, because there's a sort of limited, albeit growing, menu of treatments, but we need to decide, look, is it primarily a neurological problem? Is it a bone marrow problem? Is it both? Because then you would want to use treatments in a certain order. So what we tend to do is, if the WM itself is modest in size in the bone marrow or lymph nodes and not needing treatment, but there is a neurological problem related to the cells and the antibody, we would either just give rituximab as a single agent, or we would give it perhaps with some chemotherapy. Because once you target the disease, then hopefully you can render it negative for some considerable time, let's say, and the neurological symptoms should hopefully improve. Things like BTK inhibitors, their availability varies in different countries. So in the UK, we cannot use BTK inhibitors up front. We can only use them at relapse. And you can only use them once. You can't sort of keep going back and forth or swap around, etc. So we're very careful about using BTK inhibitors. We don't rush into them before we really need them in many ways, because once they've had the BTK, they can't go back to it. So we would tend to reserve BTK inhibitors for people with neuropathy who haven't really responded to a chemo-based or immunotherapy-based treatment, but also taking account of what their WM is doing systemically. So obviously the ibrutinib, zanubrutinib, etc., can be used. There's another class of drug called proteasome inhibitors, which includes bortezomib. Although famous for causing neuropathy, it can actually, if the nerve damage is caused by the disease itself, you can actually improve neuropathies by treating the disease and helping to clear the disease from the nerves. So these are the kind of thoughts we have when discussing or deciding on treatments. And with regards to Bing-Neel syndrome, as we heard, it may occur at the very first presentation of WM. It may occur during the course of WM when it's progressing, and it is due to direct invasion by the lymphoplasmatic cells. So in this case, although only the nerve roots were showing uptake on the MRI, what made it Bing-Neel was the fact that there were cells in the CSF. They were circulating lymphoplasmatic cells. And interestingly, this patient did not have head symptoms at all. The only area that was affected was his lower back, or the nerve roots. But it just illustrates the need to actually go through investigations in a sequential and systematic way. We heard about how diverse the symptoms of BNS can be, and often there is a considerable delay between symptom onset and diagnosis because it can mimic many other things. So this was the backdrop, and that's how we work the way through the BNS symptom system. Now, it's important to realize occasionally you may come across cells in the CSF which are lymphoplasmacytic or WM, but patients may not actually be symptomatic. So a bit like WM itself, we don't actually treat Bing-Neel if it's not causing symptoms. And I'll give you an example. We had a patient who was known to have WM. She'd had previous treatment. She traveled to Europe. When she came back, she had a severe headache when the plane was descending. And so she was very worried. The headache didn't settle for quite some time. So she came to the hospital. We scanned her. There was nothing to see. So we did an LP. During the course of these tests, her headaches actually improved and they settled. So although we actually found Bing-Neel cells in her CSF, we decided not to treat her because everything had subsided and she was fine. Some years later, she did need treatment for Bing-Neel, but for those 2 years, she was actually very well and did not require chemoimmunotherapy. Okay, that leads to our, yes.
So just for each case, I've tried to talk about, we consider all the treatments Shirley can give, but in this, going back to the gentleman, which was the second case, because he did have ankle weakness, he benefited from those ankle foot orthoses. And in his case as well, he wasn't having a very good diet. And when we think about a neuropathy as a whole, we always ask about things like alcohol and diet, because those are things that can affect your nerves and things you can do as an individual to sort of try to improve the health of your nerves or improve the recovery of your nerves and not contribute to it. So alcohol, excess alcohol in particular, causes a sensory neuropathy. So we gave him some advice about that and some advice about supplements, because you should get essentially most of the nutrients you need from a healthy, balanced diet. But some people, especially those who are consuming alcohol, can sort of neglect parts of their diet. So if needed, if we find a deficiency on the blood test that we do, we would also recommend supplements. And that would help the health of his nerves in general. So in summary, this is a Bing-Neel case that he has started treatment this week with rituximab and will have a BTK inhibitors following this, as he is definitely symptomatic and progressing with his neuropathy. And we're also supporting him with ankle foot orthoses, nutrition advice, and some aids to help his walking. So finally, we've got a lady that we've been seeing for a little bit of time, who's a bit younger. She's 57. She developed symptoms that, in contrast to the two men, they started first of all in her hands. So that is not typical for regular length-dependent neuropathy. And you'll see why in this case that her symptoms began in her hands. So they began in her fingers, with all the fingers of both hands affected, but she did then also develop symptoms in her feet and legs. She was found to have a paraprotein with heavy bone marrow involvement and diagnosed with Waldenstrom's, and actually started on some treatment, but her symptoms continued to progress. So she developed problems with balance, unsteadiness, and then a whole number of other symptoms. So she had incontinence of her urine. She also developed lightheadedness that was initially just when she was having chemotherapy treatments, but then that was present more of the time whenever she stood up for prolonged periods. So she reported this lightheadedness, feeling like she was going to faint, but also a pain in between the shoulder blades that would then get better when she sat down. So that pain is called coat hanger pain, and it's quite characteristic for people who have low blood pressure when they stand up, because the large muscles in your back run out of oxygen if your blood pressure is low. So they feel like you would feel if you've been on a long run. They feel that sort of ache when you stand up that gets better when you sit down. So she had this lightheadedness with coat hanger pain, bladder involvement, also severe constipation and dry eyes as well, and weight loss with all this. And her examination showed that her pupils were not reacting normally to light. She had foot drop, and she had weakness in her hands and her legs, but in particular on the right side, her thumb, there's a muscle called adductor pollicis brevis that we measure, and that muscle in particular was very weak. And she had sensory loss that was quite severe, involving all the different modalities in her hands and her legs. So this picture, with the thumb being affected very significantly, is quite characteristic of a carpal tunnel syndrome. So she had carpal tunnel syndrome on top of a neuropathy. And sometimes it can be a bit hard to tell if you've got a severe neuropathy affecting the hands, if you, on an electrical test, if you also have carpal tunnel. But in her case, she had both. And the other thing she had, because she had a large number of autonomic nervous system symptoms, so she had quite a significant drop in her blood pressure when she stood up. And the figure in that box is basically a 24-hour blood pressure profile. And the bit in pink is sort of the normal level of blood pressure. And every time she stood up, it sort of tended to fall, her blood pressure. And what your blood pressure should do when you're asleep is that it tends to fall naturally in sleep. You see a little dip when you go to sleep, but that didn't happen in her. It just stayed at the same as it was in the daytime, but it just fell if she went to the loo and she stood up. So all of these tests tell us that her autonomic nervous system was not functioning properly, and she also had a sensory motor neuropathy as well as carpal tunnel on top of it. So that should, if you, I guess, listening to the last talk, all of these features make us concerned for one particular type of neuropathy that is a complication of WM, which is actually amyloid. So she had this IgM paraprotein, and her initial bone marrow had shown an involvement with the lymphoplasmacytic cells. But when we went back to look at it, specifically for amyloid, we used this stain called Congo red staining, and it shows up as red on that stain. But then when you shine polarized light on it, it then shines up as apple green. So we call this apple green birefringence. So this picture was seen on her bone marrow, but she also, in the workup for this illness, she had a number of other biopsies to look for amyloid, and she actually had amyloid seen in the different biopsies she had. And we look after her together with another center in London called the National Amyloid Center, where they're able to do a whole body scan to look for deposits of amyloid elsewhere in the body. And she also had amyloid deposits seen in her spleen, and that's a picture of her scan there, showing the spleen lighting up black there. So in her case, she had a different, you can see that the patterns of neuropathy in these three cases are really different. And hers is striking for the autonomic involvement with the carpal tunnel. So amyloid has this tendency to deposit in certain places, including the somatic nerves and the autonomic nerves, and it tends to deposit also in the carpal tunnel. So that's why she had more symptoms in her hands, more than her feet, like the other two men. So the cause of her neuropathy was AL amyloid, with WM driving it. So I'll hand over to Shirley to talk about what treatment she had.
Thanks a lot. So because amyloid can affect so many systems of the body, one has to be very careful to cover all the bases. So if there is low blood pressure, then one has to give medicines to prop up the blood pressure, as in sort of anti-hypertensive. So there are drugs called midodrine, fludrocortisone, which we use. If you have heart failure as a result of amyloid, that needs to be treated very vigorously as well. People often get quite swollen limbs. They may get kidney problems, leaking of protein through the urine. So we make a comprehensive assessment of patients with amyloid beyond the neuropathy, because quite often they may have other organ system problems. And the idea really is to get them as fit as possible, because then the treatment intention is to really reduce the paraprotein, the IgM production, to a minimum as possible level. So it can be difficult because the patient can be quite unwell, and yet you want to give them fairly intensive treatment. So it has to be very carefully managed, sometimes as an inpatient, some of it, sometimes as both, with close monitoring, replacement of fluids, diuretics, all kinds of things. And often, because amyloid neuropathy is painful, one has to be quite proactive with neuropathy pain management. So this is a small I mean, it doesn't project very well, but the key thing with amyloid, and I think Shana made this point as well, is to sort of treat the underlying cause that's giving rise to the protein, which is damaging the nerves and other organs. So when we identify IgM as a cause of amyloidosis, we employ IgM-directed therapies. We more often use chemotherapy-based treatments, such as bendamustine. We also use sometimes Velcade-based therapy, because that really attacks the plasma cells. They're the ones within the lymphoplasmacytic compartment that make the antibodies. We sometimes will aim for a stem cell transplant as consolidation from yourself, from the patient, in order to deliver really high-dose chemotherapy. So we try and get people fit enough for that sort of treatment. For those who are not able to have a stem cell transplant, we try and get deep responses using medicines like bendamustine. Yeah. Okay.
So for all the other different parts of it, there are other bits that we were doing to support her through this. So she had carpal tunnel, so she actually had decompression surgery with some improvement of the severe symptoms affecting her hands, and some improvement in the power of her thumb, because obviously the thumb is actually a really important part of your function, actually. So in addition to the other therapies Shirley spoke about, she had a carpal tunnel decompression. Her pain was really significant. And so we have to be careful in some respects because she also had orthostatic hypotension. So one of the really good agents we use for pain is called amitriptyline, but in some people that can lower their blood pressure when we stand. So we managed her pain with a combination of pregabalin and a fentanyl patch. She had really significant bowel issues that were managed with some laxatives and some stimulants to her bowels. And then the blood pressure, again, that was a really significant thing that impacted on her day-to-day living. So we managed that with a medication called midodrine, which acts to squeeze the blood vessels together more, and it's taken a few times throughout the day, with advice about really, to keep really well hydrated, and other non-pharmacological strategies that people, we're lucky in the National, we've got an autonomic unit with autonomic nurse specialists. So they will go through a list of non-pharmacological measures that people can do to support their blood pressure, such as doing heel lifts before they stand up and taking their time to stand up. So there's a few different things you can do to support the blood pressure. And in her case, because she did have quite significant weakness of the ankles, she also had ankle foot orthosis and adaptations to her home to help with all of this. So in summary, we've talked about 3 very different cases of anti-MAG neuropathy, neurolymphomatosis, and amyloidosis to tell you about the range and very distinct ways that WM can cause a neuropathy. The approach we have in the neuropathy clinic to determine if a neuropathy is present, what the pattern of it is, what the cause of it is, what treatment we can do that the hematologist can deliver, and what can we support with from the neurology side. And just making that really personalized plan. I don't know if you wanted to do this bit.
Well, either of us could. So I think what Junie highlighted in the history was how to get a feel for when the condition is developed, over what time, what makes things worse, is it linked to other things, how are they affected, the symmetry of it, what helps the position, how it's impacting on function. Any other things to add on that?
Yeah. So these were just, I think Shirley said that it's quite nice for you guys to have a take home to know about how we think through things, so you know what to mention to us, so that we know what to focus on. We'll try to ask about all these things anyway, but so you know what we're listening out for.
I think sometimes when a clinician doesn't have a a lot of familiarity with neurology, it's good to give them this sort of on a plate so that they get to understand how to address the effect that neuropathies have on you. And I think if you can get to see a specialist nerve person, even within neurology, there are many different specialties. Junie and the team are peripheral nerve specialists, so that really helps to make inroads into management of this condition. That would be advised. And that concludes our talk. Thank you very much.
Thank you so much, Shirley and Junie, and a great example of the two different disciplines working together for us guys with WM.